Hello, everyone, and welcome to Talk with a Doc, the show where we bring your questions to Providence St. Joseph Health medical experts for insight and information. I'm your host, Mary Renoff, and here with me today is Dr. David LeDrew, the Executive Medical Director of the Women's and Children's Services Institute at Providence St. Joseph Health in California. Today we're answering your questions about maternal health. Remember, everyone, all of your questions come from our listeners on social media. We can be found on Twitter at PSJH and on Facebook under Providence St. Joseph Health. Use the hashtag #TalkWithADoc for your chance to hear your questions on our episodes. Before we start, I want our listeners to know that the information provided during this program is for educational purposes only. You should always consult your healthcare provider if you have any questions regarding a medical condition or treatment. Okay, let's get started by welcoming our doctor today. It's Dr. LeDrew. Well, thank you for joining us, Dr. LeDrew. Can you tell us a little bit about yourself and your role here?
Sure. So I'm Dr. David LeDrew. I'm the Executive Medical Director for Women's and Children's Clinical Institute here in Southern California for Providence St. Joe's. Technically, that role involves keeping track and helping with clinical quality and growth in those particular business lines. But in reality, I look at my biggest role as someone who's helping spread good ideas. So trying to take national and state guidelines down to the individual patient level, and also because we have so many great hospitals here in Southern California, get people to share their ideas with other folks. So
yeah, right. Why reinvent the wheel, right?
Exactly. There's it's funny you should mention that, because one of my heroes is Don Berwick from the Institute for Healthcare Improvement, and one of Dr. Berwick's famous sayings is, American healthcare has absolutely the right thing to do in everything. The problem is there's a little bit over here, and there's a little bit over here, and a little bit over there. So I think that philosophy of sharing good ideas and working together is critical.
Knowledge share is critical for every facet of our life at this point, but specifically for healthcare, yes. Yeah. Well, so you're kind of on the business side now, but you come to this as a clinical expert.
Exactly. Yeah.
So how long are you a baby doctor?
I am. I'm a what's called a maternal fetal medicine specialist by training, meaning during my clinical career, I dealt with high-risk pregnancy, mothers who had medical problems or their babies had some sort of anomaly or other conditions. So, you're right. The business side of it's new for me, and I like to think, but I still think of myself as a physician who knows a little business, not the other way around.
Well, I can speak for everybody that every single person I've talked to says you're amazing at your job, so you're clearly doing it well. So one of your biggest areas that you focus on is really improving maternal health. Why are you so passionate about that?
I think it's probably, first of all, I know the statistics. Part of my job is to deal with the data, and so I have that insight to see the scope of problems and conditions. But I think the other thing is just that's where I think my career helped me, because, when we would get called into cases, things were usually not going that right. Mm-hmm. And so, unfortunately, the experience, I think we as physicians, you tend to remember the bad cases, not the good cases, right, unfortunately. And so I think that drives me forward. So maternal safety and clinical quality, I don't see them. To me, that's job one.
Right.
And obviously, it fits in well with our mission here at Providence St. Joe's. But in reality, it's that sort of burning desire to improve things and not have those bad outcomes.
And we are getting ready to take questions from social. So, Dr. LeDrew, we're going to start right away. We've got a question from Noreen that says, women are dying in childbirth, and it's increasing. Is that because of home births?
No, I wouldn't say, at least statistically, home births are still a pretty small number. And so I don't think we can attribute the rise in maternal mortality to that. We know there are certain things, obviously, that happen during labor and delivery that it's good to have immediate response for. So for example, we talked about hemorrhage or high blood pressure problems, things of that nature. And it's still a reason, if you look at the sort of national recommendations on home birth, that certainly if you're going to choose to do that, you really need to make sure you don't have any risk factor at all. Because again, there are slight increases in complications to moms and babies that could occur.
Well, it's interesting when we talk about home births, because you think about the fact that you have a home birth or you have a hospital birth, but now we have birthing centers. How has that changed the game?
Yeah, it's interesting. There's a huge body of work going on right now on defining, we call it maternal levels of care, where we're trying to segment out, what's the role of a birthing center, what's the role of a level 1 hospital, all the way up to what we call level 4 hospitals, where you have these experts of experts that can deal with things like congenital heart disease in the mother or complications of that.
And does that include NICUs as well, like different levels of NICUs?
Well, actually, it's funny. That's a pretty established system. Okay. NICUs, level 1 through 4 NICUs has been, their actual standards and guidelines and billing codes,
right.
For many years. But we didn't have that in maternal care. And the reason, I think there's a couple reasons. One is our systems of care are evolving. So, for example, you mentioned birth centers. Well, there are, when most people say birth centers, they think of freestanding birth centers that are out in a, just like outpatient surgeries, centers and things of that nature. But you're also beginning to see development birth centers within the campus of a hospital.
Right.
So the difference being, obviously, that if there is that small number of women that have unforeseen complications, they can immediately be rushed over to get the benefits
rather than having to call an
hospital.
Ambulance.
Exactly. So where that's all going to go, there's pros and cons to it, obviously. If the birthing center is within the hospital, there's the tendency to probably react and transfer the patient over.
That makes sense.
So that kind of hurts the mom's experience and things of that nature. And but on the flip side, there are a small number of women, statistically, that will really make a big difference in the outcome for the mom and the baby. And I think the other thing is, too, that I will say, because we have a really nice example of our birth center down in Mission Viejo that's doing that, is by having it within the hospital, it means that the labor and delivery, the hospital part, is working so closely with the birthing center part. Mm-hmm. And they agree upon protocols and who's going to get moved over. And so you don't have this friction that sometimes you have when it's a freestanding birthing center and now the patient just shows up through the emergency room up to labor and delivery, and there's that
you don't know anything about them, and the clinical experts don't know each other.
Yeah. Mm-hmm. So I think there's work to be done on that. I mean, I think it's like everything else in healthcare. We work as a smooth system. It doesn't mean you can't have a freestanding birthing center and have all those benefits, but it really needs to be well structured, not just haphazard.
Now, I did get to tour the on-site birth center at Mission recently, and I don't have children, but it made me kind of want to have a baby. I mean, it was like big, huge bed, and it was aromatherapy and candles and dim lighting and a birthing pool. It was like, this kind of looks like a little vacation. So if you were having a baby, I guess it'd be a good way to do it. But I did talk to the nurses there, and they said it was so much more comfortable for them, and even the midwife said it and the doula said it, that having that ability to just go a few feet practically and have that care made the mothers feel so much more comfortable. So it was like a home birth, but in a hospital setting.
Yeah. And I think it's been fun. You know, the spinoff, too, to having that type of care in your hospital is that feeds over into labor and delivery. So, you know, the midwives are experts at labor techniques and different to your point, physiologic things that you can do. And they're actually teaching our nursing staff. So even the patients delivering in labor and delivery that didn't go through the birthing center are getting the benefit of that expertise. So it's really kind of a win-win in my opinion.
That's great. Well, the next question we have from Sandy is, it seems like more maternity units are closing around the country. Why is that? And is that part of the reason that mortality rates are increasing?
Well, obviously it depends on the part of the country. You know, clearly if, you know, you're out in very rural parts and you don't have access by a 2-hour drive, that's a safety issue.
Right.
Because complications do occur that are unexpected. So that can be an issue. Again, I don't think it's a huge part of the maternal mortality rate increase. I really attribute some of the other things we've talked about.
And that's high risk, women who are having babies later in life, women who maybe have complications or overweight, that sort of thing.
Exactly. Yeah. And and then the other part of your question was, why is that happening? And I think it's kind of generally true for hospitals in general that the small rural hospitals really can't compete. Yeah. Financially, it's a challenge. And then the other factor we're beginning to see in maternity care is we're actually hitting the physician shortage issue.
Right.
So getting enough OBs, getting enough midwives is going to be a real challenge. We've studied that in our own region. Out of our 300 some odd providers, we know that 69 of those but over the next 5 years will be at retirement age.
Wow.
So replacing that many providers, who are, by the way, some of our most productive, is going to be a great challenge for us here in the region. So again, I think you'll begin to see this. Again, it's not just our problem; it's everybody's problem, and going to be an issue going forward.
So for those of you listening who are wondering what you should do with your future occupation, maybe go into maternal medicine. We're just saying.
Yeah.
Well, another question says, are multiple births causing more issues? Here's another two-parter. And are those from IVF?
Well, there's no question that IVF leads to an increase in multiple births. Fortunately, I think the peak of impact from IVF, where we were seeing so many triplets and so many quadruplets, that has really peaked and has gone way, way down. But we do have still more twins, and twins are more complicated. It's probably more a risk for the baby in general than it is for the mother, but issues such as hemorrhage and need for C-sections go up with twins, and so clearly it's been part of the problem.
Okay, well, we're going to take a quick break, and when we come back with Talk with the Doc with our expert, Dr. LeDrew, talking about maternal health. Well, the next question we have comes from Tara, and she says, why are some states seeing more of an increase in maternal deaths than others?
Wow, that's a loaded question. Yeah, I hope I don't get in trouble. I think my accent will give it away. It's interesting, if you look at maternal mortality rates, they're higher as you go from the East Coast has more than the West Coast.
Really? Okay.
And the further south you get, the higher the rates get. So actually, my quote unquote neck of the woods, the Southeast, actually has some of the highest rates. Now, part of that could be demographics, but I think it's very interesting if you also did the same same grids for cesarean section rates. It's the same
interesting.
Grid. So again, it kind of gets back to the earlier discussion of, are we creating some of the problems? And again, it's still case by case, right?
Sure,
you can't
sure.
make gross generalizations, but I do think that's an issue.
Well, our next question says, is it more common to lose the mother or the baby in an average birth?
Well, it's still more common to lose the baby, obviously, and that's really another difficult question, because at obviously, if you ask me as a physician, or I think the same thing, if you ask me as a mother, if you had to choose between the mother and the baby's life, what would you choose? To me, it's not. It's a very simple question, and I will choose the mother above everything. Having said that, there are a lot of things that happen in pregnancies where babies have more common problems, like birth anomalies or genetic problems or different things of that nature. So yeah, it's a whole lot more babies having problems with pregnancy than it is mothers. It's just, I think, and we all feel this, boy, when we lose a mother, that's just such a big deal.
It's a very big deal.
Yeah.
Well, this question says, is the increase in mortality changing the way doctors and nurses are being trained and educated?
Yeah, absolutely, we are changing. I think it comes from the fact it kind of goes back to this experience. If you're ever at a maternal death, it changes you as a provider.
It would have to.
If you're ever at a very near miss, it changes you. That can be good and bad. You can become over conservative and do the wrong thing. But I think the collection of that. So I'll go back to some of the issues about cesarean section rate. I think the reason we've been able to lower the cesarean section rate in the last few years is because providers began to see this tie-in between these horrific bleeding cases where the placenta had grown into the wall of the uterus, and you were just lucky enough to save that woman's life through a surgery, or unfortunately she passed away, and begin to tie that back to, wow, we didn't see those back before the C-section rate was so high. I mean, the incidence, if you compare someone who's had a 4 cesarean sections to someone who has never had a cesarean section, it's almost 100-fold increased risk. Wow. So again, I think the collective experience has really changed people. And, it's really neat. You begin to see in medical school, you begin to see in residency, nursing's probably been ahead of us, midwifery ahead of us in quality improvement, safety management. Sure. Clearly these folks, but it's being built into the curriculum now. And you see the actual training. So, for example, we talked earlier about the simulation training.
Right.
And absolutely, that's something I think I certainly didn't experience in my training, but I think it would be pretty uncommon now that a medical student or a residency gets out without knowing how to do that.
Right. Well, I think it's an interesting note, though, that you talked about near misses, because even though the increase in mortality rate is increasing, the actual number of people that are saving are becoming higher as well. So it's maybe we're losing almost 1,000 a year, but there's 65,000 who were close to being lost that were saved. So I do think that's really important. But you also talked a little bit about C-sections and so forth. We have a couple of questions. One is, can I have a vaginal birth if I've already had one C-section?
The vast majority of the time, the answer to that is yes. In other words, it depends on what type of incision was made on your uterus. In general, if it was a side-to-side incision on the uterus, not on the skin, on the uterus, then it is very safe when you've had one prior cesarean. So your chance that it would hurt you or your baby to have a trial labor would be very low.
Got it. Well, this question says, what exactly is a natural birth?
Well, the reason I'm laughing is I actually went to a conference a few years ago that was put on by the American College of OBGYN, and they brought in pediatricians and midwives and nurses and physicians, and this whole thing was about agreeing on terms of pregnancy, and one was actually natural childbirth. What do we call natural?
Different to everybody?
Which I don't think even made it out of committee. No one could decide. But I think really, and the midwives like to call it more what's physiologic birth, meaning what are the things that should be naturally occurring, and what are the things that we do, which may be as, slight as breaking the bag of waters, right. We call it stripping the membranes, where you put your finger in through the cervix and sort of peel away the membrane from the cervix a little bit, and that stimulates this biochemical reaction to cause contraction. So it may be a very subtle thing, but that's not natural. And I think the whole physiologic birth movement is to try to do absolutely nothing other than have it just occur naturally. Now, having said all that, now I'm going to put my MD title on. We know if you go perfect natural childbirth, that a lot of moms and a lot of babies got hurt.
Right.
So even though we don't want to over-intervene, there are clearly things we have done. We look at the rising maternal mortality rate and we say, gosh, what a shame. But it's nowhere near what it was in the in the pre-medicine stage. So again, it's finding that sweet spot where we don't do things we don't have to do, but being ready to intervene if we need to intervene.
Well, we always give the disclaimer that people should always ask a physician first, but this question is, as an MD, for your expertise, do you recommend a drug-free delivery? And I think you kind of just touched on it.
Yeah, I think if you can, it's a wonderful thing. And the reason I say that, anything we do, whether in any drug we give you, has some possible complication. Right. So if you can avoid that and you don't need it, that's fine. Having said that, I do agree with people who say, well, gosh, Dave, would you go out and have your tooth pulled without anesthesia? And the answer is no, I would not. And so, again, I think that's one of those shared decision-making that's very important, that the provider, that me as a doctor or me as a midwife, have that conversation ahead of time before you need it, so I know what do you want me to do in that circumstance.
And when is it okay to change my mind?
And it's absolutely always okay to change your mind. Exactly.
Wonderful. Well, thank you so much for your time today. I know you were very helpful to a lot of people out there who had a lot of questions.
Good. My pleasure.
Thank you, Dr. LeDrew, for joining us today, and to everyone for listening and providing your questions. We look forward to a future topic with more experts from Providence St. Joseph Health. Make sure to follow us on social media at PSJH on Twitter and Instagram, and under Providence St. Joseph Health on Facebook. To learn more about our mission, programs, and services, visit future.psjhealth.org. Thanks for listening.